A 67-year-old male presented to your OPD with a file of investigations and says that he has seen about 4 doctors in the last 6 months. Each time the diagnosis is different, ranging from diabetic neuropathy, vitamin deficiencies to psychosomatic conditions. Does this sound any familiar to you? Hey everyone, welcome to Dr. MS Corpus. Today we are going to start our journey discussing about peripheral neuropathy. So as we have seen in the previous case, many patients have been either misdiagnosed, either due to missed diagnosis, that is failing to identify treatable causes, or over investigating the patient due to a loss of system. So to diagnose a case of a peripheral neuropathy, there is a system assigned with 7 questions in it. What are the 7 questions? What systems are involved, whether it is motor, autonomic or sensory? What is the distribution of weakness? If there is motor involvement, where is it? Proximal, distal, symmetric, asymmetric, focal or localized, generalized. What is the nature of sensory involvement? Is there any evidence of upper motor neuron involvement? What is the temporal evolution? The course of the disease, whether it is acute, subacute or chronic. Is there any evidence of hereditary neuropathies? And any associated medical conditions are present in the patient. These are all the things that we have to see. Now, see, these are the questions. Systems involved. Motor, autonomic. If there is motor system involvement, the patient will complain of weakness and atrophy. Fasciculations will be seen. Differentials will be motor neuron disease, myasthenia. Autonomic involvement, orthostatic hypotension, anhidrosis, gastroparesis, bladder dysfunctions, and the common causes are diabetes, amyloidosis and alcohol. Then the distribution of weakness. If there is weakness, that is if there is motor involvement, then you will see if it is distal and symmetric involvement, metabolic causes, more proximal, myopathies, asymmetric or focal causes, mononeuropathies and vasculitis. Multifocal causes are leprosy and vasculitis. Nature of the sensory involvement, whether it is large fiber sensory involvement or small fiber involvement. This we will discuss in detail in the coming slides. Then is there any upper motor neuron involvement? What will we see in upper motor neuron involvement? Spasticity, hyperreflexia and Babinski sign will be seen. Key cause of upper motor neuron involvement when there is a peripheral neuropathy, you must suspect vitamin B12 deficiencies unless other causes will be HIV and copper deficiency. What is the temporal evolution? Whether it is acute, subacute, chronic or relapsing type. Is there any hereditary evidence? What will we know in hereditary evidence? They will be having a childhood onset with some skeletal changes. On examination, you will see inverted champagne bottle shaped legs. And the most common condition is Charcot-Marie-Tooth disease. Associated conditions, if they are having any diabetes, leprosy, HIV patients, using drugs like isoniazid, other chemotherapy medications, or any toxin exposure like arsenic and alcohol, or nutritional. In vegetarians, B12 will be deficient. So nutritional causes must be seen. These are all the 7 questions that you have to see. Now, let us look into a case. This is a case of a 62-year-old male with type 2 diabetes for the past 50 years. Complaining of fainted in the bathroom, feeling dizzy while standing. Other history, he has a history of chronic constipation. Wife reports he no longer sweats even in summer. That is anhidrosis. What is the critical finding here? On lying supine, his BP is 145/88 with heart rate of 94. On standing, it is 108/65 with heart rate of 96. That means we are seeing a drop of BP of around 40/20 mmHg with heart rate rise being only 2 beats per minute. What does this mean? It's a case of orthostatic hypotension. Do drop the definition of orthostatic hypotension in the comment section below. So, this is a case of clear-cut diabetic autonomic neuropathy. There is no sensory involvement seen, hence it's specified as autonomic. Now, we will talk about large fiber neuropathy versus small fiber neuropathy here. Large fibers carry proprioception and vibration. Small fiber, pain and temperature. So, in small fiber neuropathy, there will be burning pains and allodynia. That is, even touch can be felt as pain. Large fiber में numbness is seen and sensory ataxia. They can't feel the ground because there is loss of proprioception. Reflexes are absent in large fiber, whereas in small fiber, reflexes are normal. Nerve conduction studies are normal in small fiber neuropathy, whereas abnormal in large fiber neuropathy. Remember this point, it will be of use in the next phase. So now we have told about large and small fiber, but let's find out what are these fibers. Basically, nerve fibers are classified into three types: large myelinated, small myelinated, and small unmyelinated fibers. Large fibers mostly are motor fibers. That's why reflexes are lost when there is a large fiber neuropathy. And sensory fibers are distributed among all the categories that we have spoken about: vibration, proprioception in large, and pain temperature in the small fibers. Right? Now look into the case. A case of a 45-year-old female complaining of my feet burns like fire, but all my tests are normal. And previous workup says the patient has diagnosed as anxiety. Normal HbA1c 5.8. Vitamin B12 245 picograms per ml. Do tell me the normal ranges of HbA1c and vitamin B12 in the comment section. Let's discuss it there. And the nerve conduction study has also been done and it's normal. The examination findings: motor and reflex normal, vibration proprioception normal, pinprick and temperature sensation is reduced below the ankles. So here we are getting our answer already. There is small fiber neuropathy. Why? Pain, temperature reduced, reflexes proprioception normal, now large fiber involvement. Nerve conduction study is normal again. B12 is normal. HbA1c is normal. That means there is small fiber neuropathy. Now we have to find out what is the cause of the small fiber neuropathy. Talking about HbA1c, it is on the upper end of normal rather than saying completely normal. So we do a test, the glucose tolerance test. Why? Because a normal test does not always mean there is no neuropathy, because we are seeing clinically that the patient is having symptoms. We have to see that HbA1c is high normal and B12 levels are borderline. Hence, we have to do OGTT. And after the OGTT, once it is impaired, then it is diagnosed as a case of small fiber neuropathy due to impaired glucose tolerance or prediabetes. Next. Now let's talk about UMN involvement. This helps us in diagnosing a condition called subacute combined degeneration, which is more commonly seen with vitamin B12 deficiency. In the previous case, we have told that the patient was having all diabetic features. If instead of that, the patient was having upper motor neuron involvement, like there was spasticity, hyperreflexia, then we would have diverted our investigation panel towards the B12 levels in specific. Like, see here. 58-year-old male, strict vegetarian, complains feet being numb and legs feeling stiff. History: progressive difficulty in walking and frequent falls with recent urinary difficulty. Sensory features: reduced sensation below T10 level. Lower limbs, ankle jerks absent, knee jerks brisk 3+, and plantar response bilateral extensor, that is Babinski's. Initially, doctor treated as polyneuropathy with gabapentin, failing to check for UMN signs. So, UMN signs were missed initially and it was treated as polyneuropathy with gabapentin. And now the patient has come with hyperreflexia and he's telling difficulty walking, there is some motor involvement. Now, what is the investigation we do to this person? we do a B12 test. On investigation, B12 showed 78. That is severe deficiency, and the patient is having subacute combined degeneration of spinal cord. That is the diagnosis. Then talking about the timelines. This is the temporal evaluation question, where if it is an acute condition within hours to days, you suspect Guillain-Barré syndrome or toxin exposure. Subacute condition, think of nutritional deficiencies. Chronic conditions, diabetic neuropathies, hereditary causes. Relapsing remitting conditions, think of CIDPs and porphyrias. So based on the duration of symptoms, we can differentiate the diagnosis. Now, when do you say a case is hereditary? By seeing at the following red flags. Once they have to have their symptoms onset since childhood or adolescence. Very slow progression over decades it will happen. Family history may or may not be present. Skeletal deformities like high arches, pescaris, hammer toes or inverted champagne bottle legs. In Indian scenario, it is often misdiagnosed as polio due to various reasons. So, in summary, what we understand is that the context we set around a case is very important. The history is must for diagnosing a case and giving proper treatment to the patient. So, the common etiologies, systemic conditions like SLE, rheumatoid arthritis, medications like isoniazid causes B6 deficiency, pyridoxine, and pyridoxine causes peripheral neuropathy. Other chemotherapy drugs and metronodazoles. Nutritionally, vegetarian diets, B12 deficiencies, gastric bypass where there will be malabsorptions, and then toxins like alcohol and arsenic. Infections like leprosy, they have thickened nerves, peripheral neuropathy seen in leprosy also. And if there is a recent diarrhea history, you must definitely rule out Guillain-Barré syndrome. This is the last case we are seeing. Now let's diagnose this case putting all the questions together. 55-year-old male, poorly controlled type 2 diabetes. Systems involved, motor sensory. Distribution, distal, symmetric. Sensory involvement, both large and small fiber. Lumen symptoms are absent, that means only peripheral involvement. Temporal evolution is chronic progressive condition. No hereditary symptoms or condition. Associated type 2 diabetes with HbA1c 9.2. And this is diagnosed as on-point diabetic polyneuropathy. What are the key takeaways from this session? Systematic approach, always with random investigation. Normal NCS doesn't ever rule out neuropathy. Always think about small fiber neuropathy. Check for UMN signs always. B12 deficiency is common, treatable condition, and context is always that matters. Often the clue is in the history, so take a proper history. Feel free to share your questions in the comment section. Do follow our Insta handle and YouTube for daily clinical pearls, and don't forget to attend our quiz. Thank you.